Texas, and has a bachelor's degree in child and family studies and a master's degree in public health. She's a certified health education specialist and is currently a full-time doctoral student at Texas A&M University, working towards a doctorate in public health degree. Prior to this, Janet worked for the city of Waco for 6 years and served as the lead public health education specialist at the Waco-McLean County Public Health District, overseeing the creation and implementation of several community health programs focused on maternal, child health, and women's health, chronic diseases, prevention and obesity reduction, and access to healthcare through community health workers. Janet is also adjunct faculty at Baylor University, teaching both in the Family and Consumer Science Department and the School of Public Health. As member of the TCHMB Executive Committee, she serves as co-chair for the Community Health Committee and chair of the Race Equity Workgroup. Please welcome Ms. Janet Jones.
Thank you, Gloria. I appreciate that. I am going to introduce our speakers for our next session, incorporating the voices of patients and families impacted by disparities in quality improvement projects. I have the pleasure of introducing both Marie Abraham and Latasha Rouse. And so I will give you both of those introductions. So Marie Abraham is the Vice President for Programming and Publications for the Institute for Patient and Family-Centered Care. Since 1996, her work has included providing consultation, training, and coaching to organizations that are working toward patient and family-centered change and building partnerships with patients and families to improve and redesign healthcare. Marie serves as lead faculty for the Vermont-Oxford Network Newborn Intensive Care Improvement Collaboratives and served as faculty and consultant for the National Initiative for Children's Healthcare Quality. She was a founding member of the American Academy of Pediatrics Parent Advisory Group and brings her professional and personal passion to her work. Latasha Rouse is the owner of Birth Sisters Doula Services, where she is a birth and postpartum doula, childbirth educator, and lactation educator. Her work as a patient partner began after the emergency vaginal delivery of her triplets at 26 weeks, 6 days. Over this time, her passion to help connect patients, caregivers, and clinical staff and quality improvement grew to allow her to work at all levels of patient and family engagement. Latasha is now a member of the Board of Directors at the American Board of Pediatrics and Board of Directors at National Initiative for Children's Healthcare Quality. Currently, she is also the co-chair of the National Network of Perinatal Quality Collaboratives Executive Committee. She has obtained her Diversity and Inclusion certification from Cornell University to add to her expertise. She also consults with hospitals and organizations in all areas of medicine to bring her knowledge and experiences to their patient engagement initiatives. Please welcome both Marie and Latasha today for our session.
Thanks, Janet. Can we have the next slide? Hi, Latasha.
Hi.
So we're very, very excited to be here today. This is such an important topic to both Latasha and myself, and we hope that you leave today inspired, but also informed, and also with several practical strategies that you can use in your work. Yesterday, Dr. Bingham in her session had a wonderful quote. She said that quality improvement can feed your soul, which I firmly believe that's true. But we believe also that incorporating the voices of those who are too often left out of quality improvement will certainly bring an abundance of nourishment to your soul as well. Latasha, did you want to say anything real quick?
That quote is, I'm good. That quote is absolutely true. And that's what we're going to talk about.
Great. So we, as you can see from the agenda, we have a lot to cover this afternoon. We're going to start with the rationale for engaging individuals impacted by inequities and disparities in quality improvement. We'll explore some overall best practices and some examples in the beginning, and then together with you, discuss the challenges that you may be experiencing currently or anticipate. Before the break, we'll take some questions and comments. And then after the break, we'll dive a little deeper into some best practices and practical strategies for engaging individuals in QI, as well as strategies to learn more broadly from individuals impacted by disparities. So we're going to end with questions and comments. We welcome them. We'll try to keep our eyeballs on the chat as they come in, but we've left a lot of time for comments and questions. Next slide, and I'm going to hand it over to Latasha.
All right. So, as you heard, we're going to talk about the rationale for engaging underrepresented communities in QI. Next slide. Let's talk about some of the root causes for exclusion. You know, historically, there has been a lack of understanding that different patients have different experiences to share. You know, in the beginning, with a lot of patient and family engagement, people were reaching out to people who they knew, who were in their circle, and that kind of thing. And now we're starting to see people say, "Hey, we're missing something. There are some other people who need to be engaged, and we would like to find ways to make those connections." You know, the disparities that exist in healthcare lends to want to know why. As far as the patients, the patients and the NICU parents, being able to shed light on some of the gaps in care and the experiences that they have had. Also, you have with that bias and that idea of being able to navigate to people who are more similar to you and who are in your circle, but also just not so sure of what you would be able to obtain, because most of the time, people in the past had a lot of interaction with people of color at work, and then what they were seeing in media. And so being able to come out and into context and meet different people, it means that you're able to work on inclusion, and so that some of those, you're more aware of your bias. But in the past, it has been not really the conversation. So I'm excited to be here and have this conversation with you all about this, because it means that you're more aware of how much more work we have to do. And then next, not having those connections, as we mentioned, you have to be very intentional about making the connections and about bringing in people who might be different from you or who are underrepresented on your committees, on your councils. You have to be intentional. It doesn't just happen. And I think a lot of times people thought that would be so, that it would just happen. But that is not how it is, because a lot of times people have had not so great experiences, and to want to be a part of something like this would mean that they would have to be near people who maybe weren't necessarily what they needed at the time. So you have to be very intentional about how you go about that. And then just patients having a lack of awareness of QI in general, like what happens to the information that I give when I show up and they ask me about my race, ethnicity, and language, and my outcomes. What happens with all that information? Some people don't know that it is being utilized and how it's being utilized, and how that can impact the community. And so I think being more aware of that and helping people to understand what QI really is and how they can impact care through QI. And then, understanding that the more diversity you have, the more diversity you will get. So making sure that when you bring people in, you're not necessarily, you're being strategic about your cooperation, your collaborations, and you want to be able to put, people in positions where they can actually draw other people in. So you want to make that a goal, and help people to see how we grow this thing. So the more diversity you have, the more you're going to get. And then also, sometimes one of the root causes for exclusion is that people are not wanting to share their trauma. They don't want to revisit, and that is understandable. It's not going to be everybody. So it also means that once you do have people who represent a community that you would like to impact, it is much easier to work on keeping them than getting more, right? So we want to be aware of that and make sure that we are providing people the best experience possible. Next slide. Okay. And so why does diversity matter? We're learning from people, and they're sharing information that, um, that from people who are most vulnerable to the mortality and the morbidities that happen in the healthcare system. You are looking at some of the barriers that exist. And one example is, I remember working in the hospital, and there were people who literally were in the NICU, staying in the NICU with their babies because it was a long haul, and they were moving and transitioning. And so they literally were staying there while their babies were there. And so anytime they had to eat, they had to leave their babies. And so a lot of times that barrier meant that they were not able to um, eat the most nutritious foods while they were trying to breastfeed and be with their babies. They were snacking and eating quick things that they could kind of grab and come back because they didn't want to be away. So being able to look at those policies and find equity in those policies and hearing those experiences could absolutely lead to changes in outcomes. And then, the choices that people make are dependent upon the options that are available to them. And then also just the perception of what options are available. There are so many times where assumptions are made that people, don't necessarily give all the information or don't explain it fully because of bias, of the idea that maybe this person won't understand or they won't take me up on the offer or any of those things. And so that means that some of those options are perceived to not be there, but they really are there. And then sometimes there just literally are no other ways that people can actually function because of their life. And so making sure that we try to design policies and um, you know ways for people to engage healthcare that means that they are able to do it in a different way by mitigating some of those social determinants. And then also these experiences and choices, it shapes how they move through healthcare, how they view healthcare. And so some of the trust building may be something that happened a long time ago, may have happened to their family members and not necessarily to them. I've seen women in labor just really afraid and saying, please don't kill me getting an epidural when they have heard about that. This is their first child. They've heard about the things that can happen. And so just being afraid to even be near a nurse, being near a doctor because of what is out there. So being able to partner means that you're also building trust because the people that you partner with know other people. And so you begin to build trust within systems by engaging with people more. All right. And so it is, research says that teams that have diversity, they improve their performance by 50%. And we're going to talk about that because a lot of people believe that if they are bringing in patients, that it will slow them down. But what research truly says is that the more diverse groups uh, move faster through their process of improvement. And also, you want to know that a lot of times, and this is something I know I've heard this from different organizations, but there's something called a curb effect, a curb cut effect. So in all of the work that you do, you're seeing these changes slowly over time. One good example is when we first started out, when I had my first child 12 years ago, there were no balls, those peanut balls, those round balls. They were not in the rooms. But when people came in and started expecting those things, and when people came in and started asking for those things, it changed healthcare. This is also true if you focus on underrepresented populations. It will change healthcare because the things that you will be doing to improve care for underrepresented populations will automatically improve care for other people. And so this link here talks about different examples and how this actually works and how it improves everyone when you focus on underrepresented communities. All right, next slide. All right. So we would like for you to tell us, do you have experience engaging families impacted by disparities in QI? And if you do, you can just raise your hand. Okay, we're seeing a couple. All right. Marie, did you want to hop in?
Yeah, I see that, some people are answering yes, but the majority of our participants here today seems like there's not that same experience. So, um, so next slide. Thanks for answering too. So, this isn't a new approach, what we're proposing here to quality improvement. It's been around. Other organizations um, have brought in people who are, well, what has been said before, hard to reach, but they're not hard to reach. We just don't do the reach out to them. So I want to call attention at this point just to two organizations, because after our session's over, they have great resources for you. So I wanted you to be aware of them. Patient Voices Network is an organized community in Canada. It's made up of patients and families that collaborate very authentically with the healthcare system, and they've been doing this since 2010. Their mission is to advance authentic engagement, and as you can see, they believe firmly that healthcare improves when all that are impacted by decisions can participate and provide input into the decision-making processes. So it's a great resource. I highly recommend that you see it. Next. And then, next slide, excuse me. The National Institutes for Children's Health Quality has a really long history of involving families and community members as partners in improvement. It goes back, gosh, I want to say 2 decades. And they too recognize that by elevating the lived experience of community champions, we can better drive changes that will close the gap in health disparities. They also have a great resource for improvement through a racial equity approach. And I should go back and say that that other resource also has key strategies for integrating diversity, equity, inclusion into improvement partnerships. Next slide. So we're going to spend just a little time exploring those general best practices. So Latasha is going to start us off with a real great foundational approach with an activity for quality improvement.
All right, next slide. Just as making the connection, we do a lot as far as data. We look at data often, but we forget that data is a story without context, and it wipes the tears away. Those tears that you never get to see, or in some that you do, don't appear. So the context of having data and story together can help us make the improvements, because you can understand how you can fill in the gaps. There are many stories that if you looked at the data, you don't necessarily see that there were any kind of inequities. There are stories that if you look at the inequities, it will explain, some of the data points, depending on the ones you're looking at. So you do need the added context of the story. So what we're going to do next is we're going to look at how we can pull out improvement ideas from stories, because stories are powerful. But we have to act on them. They can't just be stories that are told and that people hear in a room and they empathize and then they go back and do everything the same way. We have to make improvements based on what we're hearing. Next slide. Okay, so we're going to show these videos. The first one is going to play now.
When something doesn't feel right. So just knowing that and not stopping at no, I'm just glad I did. I'm just really glad I did. I have two kids. Our daughter's name is Zion, and our son's name is Zeus. My second pregnancy with Zeus, we didn't know what we were having, but we were excited. We were going to wait until delivery to find out. My goal was to have a VBAC, which is a vaginal birth after cesarean. My water broke on the 19th, on a Sunday, and he didn't come until the 21st. Yes, the 21st at 4:41 a.m. After I delivered my son, is when the complications happened. I was having, the first day was fine. I was up walking. He had to go to the NICU. I would walk over to nurse him every 2 hours. It was fine. I was good. Everybody thought, oh, you're doing really well. Day two, I started to get the soreness started to kick in, and I started to have some pains. By the end of day two, the pain got a little worse, but by day three, it just didn't feel right. I asked the nurses, explained my symptoms and that I was having crazy pains, and they assured me that it was just gas. I felt like I don't think that this is normal. I don't think that I should be feeling like this, this long. And I mean, after taking all of the medications that they're giving me, you name it, gas X, suppositories, pain medicine, morphine, and I'm still having these pains. This can't be gas. I'm convinced. I started to have crazy discharge, very odorous, and I immediately went to the emergency room. So I went to a different hospital, and they found an 11 centimeter abscess on my uterus. And they said that had I not come in, it could have easily been a there's nothing we could do situation. Had it gotten into my bloodstream, it could have been uncontainable. My son was 18 days old, and for 13 days, I'd been away from him. So yeah, I'm glad I didn't stop at no, and I'm glad someone finally heard me. Someone finally listened to me, and didn't just take the generic "it's just gas" answer. So even if those around you aren't listening, or they're trying to pacify what you're feeling and telling you this is just normal, trust your gut and know that it's not normal if you don't feel it's normal. And tests may come out, to say that it's perfectly fine, but you'd rather err on the safe side and know that you're okay. So I'm grateful to be here. I'm grateful to be.
All right. So, what I would like for us to do is we're going to work through pulling out improvement ideas from what she just said. So what were the challenges? You can just put them in the chat. If you feel like coming off mute, that's okay, but our chat might actually be easier. If you could put them in the chat, what were the challenges? And then how might we make an improvement of this person's care, of her baby's care? Let me see. When you hear her talking about having, one of the things that struck me, especially as a NICU mother, is hearing her say that she was away from her baby for 13 days.
Mm-hmm.
What are some things?
Good ideas being chatted in, not being heard, concerns were ignored, pain that didn't resolve, staff wrote off. Her worries were dismissed, people ignored her.
Right.
Staff education.
An improvement would be staff education.
Mm-hmm.
Mm-hmm. And yeah, being able to, discussing the concerns more, getting more information, making that be a normative next step. Standing in the patient's shoes, that has helped a lot of people to actually go through healthcare and have these experiences. Right. Being able to hear all of these are very specific as to what we could have looked at here, but not listening and being an active listener. I see that coming through so many times on having missed those opportunities, to the point that she went to a different hospital. She didn't go back to the same place because she didn't feel heard. And it was a great decision. Yeah. And so another thing to think about is hearing her say that she was away from her baby for 13 days. This is a way to bridge the work between the OB side and the NICU side. This person, what opportunities are there to make sure that she's able to have those connections with her baby, in the hospital, in the same hospital. Right. Definitely. She shouldn't have had to go, but I'm glad she did. I'm glad she knew enough to do that. There should have been follow-up with her from her care team when she went home, knowing that she had those concerns. That's a great improvement. The follow-up. Sometimes it comes in the form of a phone call. Some hospitals do that, where they check in with you the next day. Sometimes it is in the form of a survey, or some hospitals even have different ways, the medical charts, those kinds of things. There are so many ways to do that. Yeah. And then, you hear about hospitals who have the access of the iPads, and being able to have babies and moms be able to, babies be able to hear their mother's voice. It could be a phone call to her room, so that you could put the phone in there and she could talk to her baby. Those are things that matter to people. It's not, there were so many medical things that could have been done, but there's also many things you could have done to improve her experience, having a baby and not seeing them for 13 days. Cameras. Yeah. The web links. I love it. And so when you see all of these things and you're looking at all the different improvements that could have happened off this one story, and this was a short story that gave you the nuts and bolts of what she wanted to say. And you can see so many different things that you could pull out of that and make improvements on. So if in fact you are working with a team, you're looking at, what were the challenges? What might we improve? for this, what might have improved this person's quality of care. And then, do we need to ask other questions? And I saw some of those pop in on, did this happen and did that get checked? And what were some of, we need more information. So you need to go through those stages. And then as a group, with your patient on your QI team, then you want to go in and decide, how do we synthesize these? What are some of the low-hanging fruits that we can pull and make improvements on based on what we've heard? How does this tie to what we are working on currently? Did the person receive respectful care? Was there communication breakdown? All of those things can be spun into initiatives or piece of initiatives that will make improvements, because then you're going to start to run those small tests of change. You're going to have the brainstorming idea, and you're going to move that into your improvement cycle to make sure that it's not just a story heard, but it was a story acted upon. When you bring them into your work, it's a story acted upon. Okay. All right. Do we want to do the other one really quickly now that you guys got your feet wet and you know how this goes? We have one more, and these are all on the Hear Her website. So you can use these with your teams and do this same practice with your team members who may not be here, or other team members you want to bring in. All right.
Being a mom is everything to me. It is truly the most amazing feeling in the world to have someone that depends on you and someone that loves you unconditionally, that you can love unconditionally. I want to share my story to help other women speak up and be heard. My daughter is 6 years old and she's sassy. When I first found out I was pregnant with Peyton, I was extremely excited. It was one of the happiest moments of my life to know that I would be bringing a little person into the world. I had one of the worst pregnancies ever. My symptoms started around 2 months. It was fairly early in my pregnancy, so I had a long time to have a very tough pregnancy. I didn't have what I needed, the tools. I didn't know who to talk to or how to talk or how to speak up for myself. I would have a lot of pain that I just couldn't explain. Because it was my first pregnancy, I always assumed that it was just normal, and everyone tells you every pregnancy is different, so you just assume that it's part of pregnancy. Your body's changing. You're going through so many different changes that you're not aware of, or something you've never been through before, so you just assume maybe it comes with the territory. I talked to a lot of different people. I tried to talk to my doctor. I even talked to my primary care physician, who's not even my OB, just to get information. Did a lot of research and a lot of Googling. I was scared. I was scared a lot of the time because I just felt like no one heard me. I was having headaches. I would be dizzy a lot. I would experience a lot of pain. And I just knew things weren't normal. My primary care doctor advocated for me a lot to switch my doctor. Had it not been for my primary care physician pushing and advocating for me, and even friends and family, a lot of people just said that it's not normal. And if you feel that something is wrong, then there more than likely is something wrong. It's extremely important to hear women because you don't know what they're feeling, but they do. Hear her.
Okay. So let's do it one more time real quick. Let's go through and talk about, some of the things she said. I remember her saying it was the worst pregnancy she's ever had. What were some of her challenges? And then, what do you have other questions, or do you have ways that you think, could have been improved? What are you hearing from this patient? Validating concerns. Right. If you feel like something isn't right, it's usually not. Yeah. Pain started in early pregnancy. Afraid to speak up. Be an advocate. Yeah. and making sure that we open the door for people to be advocates for their own care. Yep. Headaches early on. She voiced that she didn't have what she needed. Yeah. Yeah. And this also brings to light the work of, all of her care team. So she had a care team and she had someone that she could go to. Um, and so that was, you know, benefit to her. And, the education from her OB. Yeah. Asking questions is okay. She didn't feel empowered. Yes. Yeah. And so that brings to the point. Someone said she loved that her community encouraged her to continue to seek answers. Um, that brings to light community education, right? Someone knew something wasn't right and they were encouraging her to go forth. How many opportunities do we have to educate the community right around us? Right? Okay. Yeah. Systematic and implicit. Um, yeah. Okay. All right. So we would take these ideas. Again, there are so many different things you can do with this. You would take these ideas and you would synthesize, come up with something that connects the story and what you all are working on, what's important to you, and that becomes, a quality improvement initiative that you can now act upon a story and not just hear a story. All right. So here are kind of the questions that we just worked through as a group. I read them to you, but here they are as well. And so you'll have that. And next slide. All right. I think it's your turn, Marie.
Thanks, Latasha. I was like, that those videos are great, and probably a lot of you were at the session yesterday where we had several parents sharing their stories. So it seems like, again, we have an abundance of ideas, but those are ideas that aren't coming from the people that you're serving. So I'm going to take a step back a little bit to just start thinking about how you can build relationships and build those partnerships with individuals that you want to engage with in quality improvement. So at IPFCC, we did a 2-year project that focused on exploring exemplary healthcare systems and research centers that were working in partnership very, very authentically. And while this is, it was focused on research, I just want to bring attention to these principles because they are applicable to any partnership, including QI. So these, if you can go to the next slide, please, that'd be great. So I'm not going to talk about each and every single one of them. I really just want to talk about those that we want to make sure that you leave with an understanding. So by far, trust was the most essential principle that people discussed over and over again. Without trust, there can't be any authentic engagement. And it does take time to build and should be paid attention to before starting to work or even recruiting others or recruiting families onto your QI work. But if you want to engage a community, a particular community, you have to get to know them. And we all have our biases, as was pointed out in those 2 stories. And I think that we really need to think about how they skew our perspectives and address them by learning from each other. And once trust has been built, you really need to honor that trust by engaging them respectfully throughout every stage of the project. Don't just bring them in to share their story and then walk away. You want to bring them in and engage them ongoingly. And ensure when you approach the relationship, the working relationship, that each each person's experience and insight and voice are listened to. And also just make the effort to fully understand the historical perspectives, experiences, and current realities of the partners. That's really paramount to you developing that trust. Next slide. Honesty and transparency were very important for productive collaboration. And in the interest of time, I put these two together, even though when we developed the guide that I'm sorry, I didn't even mention the guide. We did develop a guide based on these principles, but we describe them separately in the guide, but there's some overlap here. So open and honest communication among team members is essential and will support your achieving success. Together, you have to kind of think through the expectations for what honest communication means. How are you going to work together? What's honest communication going to feel like, be experienced? Just all the team should discuss what that means. I don't probably have to say this to all of you, but when you're working with people who are not, you know, healthcare staff, make sure that the information is shared in the language and a method and the manner that's most supportive for them to be engaged. Make sure that the goals and timeline for any project are clearly identified and explained and understood and agreed upon by everyone. So you don't want people not understanding what the timeline is for the project, or what the activities are, or things that they really need to know. And when decisions are being made about changes or improvements, try to make them together. Now, that's not always possible. There are maybe some policies or practices that will prohibit a change to be made. Well, if that's the case, just make sure that you're explaining that to everyone. Next slide. Co-learning is just a great way of engaging and building those relationships. And what this means is that in the process of working together, you're embedding opportunities to learn from each other, and they're consciously integrated into the work. So each individual, you know, it doesn't matter if they're a family partner, a clinician, or a staff member, or a leader, they all bring expertise that's going to be important to quality improvement. So make sure that you are acknowledging and making the most of everybody's expertise. Provide training and preparation for families to understand the basic process and language of QI, and Latasha is going to talk about this. They don't have to become QI experts. A lot of people tell us, hey, we just want to get our feet wet. We need a little bit of information, but we really want to start working, and then we can tell you what we need to be more confident and more productive in meetings. And staff and clinicians should learn about different strategies for engagement. But again, Latasha is going to speak to this later. So using those key principles will facilitate the success of authentic engagement, especially for people who have are impacted by disparities. The next slide. I'm going to actually skip over these two slides. They're basically just sharing some examples, but I'm just conscious of time here. But Latasha, why don't you speak to this particular example? You're on mute.
Great. Okay. I work with the Illinois PQC on engaging patients at all level of their PQC, and working with them as far as the cornerstone of their birth equity initiative was patient engagement. And so they went and they partnered with a community-based organization that was able to bring in patients, underrepresented patients, and hear from them in focus groups, which I had co-led the focus groups with the PQC director. And we had these patients be able to open up and say things. And clearly there was a difference because when they came in, they saw a person of color. And so they were much more open, and they got so many different um, comments that they had not gotten before. But the focus groups were centered around what is respectful care, what you know, what experiences have you had, what would have made it better. And so they were able to help create a tool that the hospitals then were able to use that would help patients learn about respectful care and would help hospital staff learn what patients wanted in their care. That ended up becoming, something that was so beneficial to that system. And then also just in helping with decision making. So, what things were we going to have to, when we get down to the cuts and the sizing, and like what kind of things do we need to cut? What do we need to emphasize? We also had the staff members from hospital weigh in on the tool, and they had very conflicting points of view from patients, but we centered it around patients. So we did go with the patients when it made sense. And then also just bringing that patient and family perspective into the regular meetings. Some people forget about how important it is because sometimes you can add in, and some of the ideas you guys were naming would probably be things that patients would also bring up. And then it gives you that extra layer to make sure that those things don't get forgotten, because your inclination is to go towards the medical and the clinical, which it should be, but there is another part of this that we need to pay attention to. So the links are there, but that was a wonderful experience and a good way to think about how you can incorporate patients from underserved communities, making connections with community-based organizations, starting with focus groups. And then there may be people who want to continue on. They may want to be a part of more work. And so you start to build through that process. Next slide. All right. So what challenges do you experience or anticipate?
You can chat in again.
We heard that a lot of people had not done this. We want to hear what is the challenge with getting started, and are you hearing some things that are helpful? Got a couple people entering.
Mm-hmm. Yeah.
Want to see a couple staff buy-in. That is one that gets brought up a lot, and making sure that staff are ready to have patients involved, because that is a culture change. That is not always what they are necessarily used to.
Mm-hmm.
It's hard to work with hospital systems as a community organization. They often don't want to listen. So there's some bridges to build with community-based organizations,
Right.
because you have to have trust with them as well, because they will not let you have access to people and work with people that they built trust with if they don't have trust with you. That's a good one.
Yeah.
Yeah. Scheduling. Times between when staff are available and patients are available. I'm seeing recruitment, more physician buy-in, um, timing, scheduling. Hard to find the time. Right. Buy-in. Okay.
That's come up a few times.
Mm-hmm.
Mm-hmm. Yep.
So, Okay, finding common ground and aligning missions to find a singular effort. Then just diving in. Too much time to think doesn't move the needle. Correct. Yeah, you do have to get to that. And so sometimes, framing that and helping people to see actually what you're trying to accomplish can help. Follow up on referrals, dedicated non-clinician time to, yep, compensation. Here we go. We're getting them all now. Scheduling.
Yes, we
Yeah,
are.
coordinating efforts. Okay. Okay. So you guys did a master class in barriers and challenges.
Hmm.
We've got everything here. That,
Yep.
yeah, budgets. Okay, good. So we've heard all of those things, but there are people who have done it, right? So we know some of these barriers are actual and some are perceived. So we'll talk about
Mhm.
it.
Yeah. We hope we leave you with information to overcome these challenges.
All right. Are you ready to move?
Sure. I think the next slide is just it's just the summary of the challenges. But I think
Mhm.
we probably got quite a lot of these in the chat. Is that right, Latasha?
Right. We did. I want to point out the one on the financial concerns for families. So while you have financial and budgetary patients in the families, and especially in underrepresented communities, being a part of something like this and seeing everyone around the table be paid, and this is their full-time job, and you are not, it stings. So finding a way to bring about some type of appreciation is important. So I know that that can be a challenge, and especially starting out. But as you start to grow, you have to build that in. Otherwise, you won't be sustainable because that is a concern. We didn't talk about technology, but yes, being able to, technology could be a barrier for some families. Transportation, childcare for families, just the scheduling. Yes, we heard that one. The trust and the language. We can't speak in alphabet soup all the time. We have to break these things down for people who are entering our space who may not have had these acronyms thrown at them, right? And then I don't think this one was mentioned, which was data sharing for the staff. So I didn't see anyone say we are worried about providing our information to patients and families. That does come up from time to time.
Mhm.
And what usually happens there is you can absolutely have patients and families and should sign confidentiality agreements. Just like any other volunteer in your hospital, they need to go through the volunteer process and fill those out because it builds trust with staff. It helps them to make sure that people understand what they can and can't share. Um, and we did address a little bit of the slowing down the process and how that's not actually so. Um, and then the rest of them were mentioned.
Mhm. Mhm.
All right, next slide. All right.
So we put together a packet of resources for you for after this session. And there's a tool that we've included in the packet that explores, and this is to be done before you recruit and invite people into your QI. It's really a conversation for the teams and staff and clinicians and leaders to really dive into. It's a readiness assessment. And, somebody did put early in the chat about the privacy issues, and that certainly is that, you know, sharing data. And as Latasha said, you know, they have to go through the same HIPAA privacy training. If you're still uncomfortable with that, go through the training that the staff go through. So that's also a way that people address that. But anyway, the readiness assessment tool just asks a team to kind of explore what they are most hesitant or reluctant about. And sharing data is huge when it comes to quality improvement. They also don't think that it's necessary to involve family partners because why? What do they bring to the table? You know, you have to really think about that. Maybe it's going to slow things down. These are all huge barriers. I think they're exacerbated when you're trying to bring in individuals who are the most impacted by disparities. So if you don't have experience working in quality improvement with family partners, or even if you do, but you are kind of a little bit challenged, I would ask you to use this tool to reflect on the underlying concerns. The tool itself takes you, you know, looks at all these areas, and then you can kind of map out where you are. So you know, okay, we have to go to that underlying concern before we can bring people into this. Otherwise, it's not going to be very meaningful. So this packet is available to you. It was, I think, and somebody from TCHMB can correct me if I'm wrong. I think it was made available to you before this session, but if not, it will certainly be made available after this session. So these are the challenges to start thinking about. And I think somebody mentioned leadership, and you need leadership, because if you don't get leadership, you don't get a lot of things, including your budget and the funds you need to get this going. So with next slide, I think, is moving into our Q&A. So we've got some minutes before our break for Q&A. I know that yeah, go ahead.
Oh, sorry. I was just going to remind everyone to use the chat if you have questions. I do have a couple that have already come in that I will go ahead and start with if you all are ready. The first, as one of our attendees mentioned, because of patient confidentiality and protection, we do not include the public in QI. Can you please share your thoughts on this?
So the concern is if you bring patients in who want to share, that you would be violating them in some way, if I'm understanding. And actually, that is not really what's happening, because they are coming to you saying they want to participate. They are going to go through your volunteer services and sign confidentiality agreements, and you can absolutely be cognizant of the fact that they might not want all of their videos and everything that they provide you out there and ask the question about what you put out in the public forum. But if they are telling you and coming to you and saying that they want to share, actually, I think it is healing to be able to share. A lot of my healing has been from being able to share and hear different perspectives on my care and my challenges that existed. So it's actually a gift to have them be a part for both of you. It's a gift for you to have them, and it's a gift for them to have you. And over time, those relationships mean a lot. So I would hope that you would revisit that, because there are so many benefits, as we've already talked about.
Okay. Janet, I see a follow-up to that about the sensitive information shared in quality improvement discussions. And I just, you know, there are a lot of large-scale collaboratives that are doing this work and sharing data. And I know it is huge. It's a huge barrier to get over. But remember that if you're the patients and families who are coming into your organization, kind of, they know the experience and they know the good and the bad. Yes, they if it's sensitive information, for instance, someone's name, then don't, why is that being shared in a QI meeting? Take the names out, de-identify the information, give the data. But so make, I think that's just kind of good working around QI. You want to see the data, you want to hear the stories, but you don't need to have the names connected to that.
No, and I can even remember doing a focus group where we didn't even let people come into the focus group under their name. They were all given a color. So it was blue patient, purple patient, or blue, just simply blue. And they, or names of flowers, So you can come up with different ways to make sure that you're respecting them. But if they're there, it's because they want to be.
Mhm.
And so, revisit that policy.
Yeah.
Thank you. We have another question. What do you do if staff refuse to support equity initiatives?
Well,
Yeah.
that's a big question.
Yeah.
Yeah, there is, I think there's power in awareness, there's power in trainings. And, so I've seen some really good ones that help people to see what truly the experiences are, what the biases are, because it's not just race, ethnicity, and language. It's all kinds of different bias. So being able to look at the full spectrum and then looking at something like Patient's Bill of Rights and looking at how these biases can absolutely impact whether or not these things happen.
Mhm.
That's powerful.
Mhm.
Because you can look at it and say, well, I don't know how it ever happens. If you really know how many, opportunities there are for bias to slip into decisions and actions, right? That's one good way. But trainings help, exposure helps, hearing the stories helps. And it may mean that it takes some time, and that's okay. Everybody doesn't get on the same train at the same time, but we're going the same direction, we hope. Okay.
Yeah.
So give people the opportunity to grow.
Right.
And don't make them bad for it.
Mm-mm.
Thank
No,
you,
and I would
Latasha.
say that if there's still, if there is some reluctance to engage in that kind of work, I would say that doing some very well facilitated reflection groups or even individual, finding out what's the concern, what's behind this, and sharing, I would say, I mean, we saw that data yesterday in the sessions in the summit about the disparities. That's real, and that should push us um, into wanting to improve and close those gaps. I mean, they're quite startling, and it's not just Texas; it's everywhere. So, I would say training, give them the data, explain, reflect, and if you're hitting that hard wall, then some decisions need to be made, I would say. Oh, that was rather strident of me. I'm sorry. Sometimes I don't have patience.
Thank you, Marie. That was honest. We have just one more minute. And so I think I'm going to hold off on this question because I don't think it's one that you could answer in 1 minute. So to keep us on track, I'm going to go ahead and adjourn us for our break. We do have a 15-minute break coming up at this time. And so we will come back and continue and pick up this session at 2:20 p.m. And so you all can take a bathroom break and we will resume right after that.
All right. Looks like it is time. And we are back to talk about strategy. So we've had discussions around reasoning, why we would do this, how, um, what we should be doing, and then we're going to talk about how we do it. So the question of recruitment, preparation of patients and families, preparation of staff, what is meaningful engagement, and how do we sustain it? Next slide. All right. So as far as recruitment, you want to know um, who do you serve? You need to know what your population is, and that way you know who to bring in. I have seen hospitals not ever run their data by race ethnicity, and they find that there was a whole population that was coming in and out of their hospital and they didn't know it. Spanish speaking populations, different types. So knowing who you serve and seeing where the gaps are in who you are currently engaging and who you need to bring in. And then you want to ask around, talk to the staff members, the clinical staff, doulas, nurses, midwives, who are patients that they are in contact with and that they know that might be good additions to the team or for a specific project that you're working on. And then also take a look at those surveys that come in. That is actually how I got recruited. My survey that I filled out after having my kids, it was very lengthy. I had lots of things to say and to point out and questions that I wanted to know about how things should work. And, so that shows you that there's a person that's interested and they are paying attention to the different experiences that they're having and how that impacted their care or their experience. It's important to look at those. Don't just have those go away. Also, if you have other hospital patient family advisory councils, so if you are on the maternity side, you can also know that the people on the NICU side likely had a maternity experience. And so those people you could also partner with, and vice versa. And then also outside, if your hospital has councils in other departments or a hospital wide council, those are areas that you could also recruit from. You could also work with community leaders, asking for referrals, ask to speak, ask them to spread the word about events that you're going to have, initiatives that you're working on to the communities that they are involved with, but make sure you build that trust. So this can't be a one-sided relationship. This has to be reciprocal. So while you're asking for help, you're also looking at ways that you can impact them. Do you have an office space, a meeting space that they could use? I know COVID is different in all the places, but think about ways that you could benefit them as well and build that relationship. Being able to attend community meetings and promote within those now, especially knowing that there are so many meetings that are online even, you could absolutely do some of those meetings and be able to talk about the work you're doing. And so finding out what's going on in your community and opportunities for you to be present for 10 minutes of the meeting to kind of talk about what's going on. And be able to promote it. Don't forget social media. I know some of you are wonderful at TikTok, and I I want to see all the videos, but even if it is your Facebook account or your Twitter account, use those. Make sure the information is on your website. so that people have access to it and it doesn't seem as though it comes and it goes. It's a continuous recruitment process. It's not something that only happens in certain seasons. And then you're also going to look at the health education support groups in your area. You're going to look at opportunities for radio and newsletters. I know here for our news, for our radio station, there's an opportunity for organizations to talk about community events or opportunities. And so they pick certain ones to shout out every now and again. And so even like during, the COVID surges, you would hear so much information about where to go for testing, where to go for shots, and those are still opportunities for you to do this type of work in recruitment as well. Next slide. All right, so how do we prepare patients and families? You want to make sure that your roles and responsibilities are clearly defined. They want to know all the information about what you're working on, how long you're going to be working on it, how long do you need them, what are they actually doing beforehand, so they can make an informed decision. You don't want to have somebody build a relationship and then they find out that they can't even participate because of the time of your meeting, right? Because of the time commitment and the frequency of your meeting. Whatever it is, you want to make sure that you are upfront about those things. And of course, if you can mitigate it, um, most of the time you're thinking about people who are working. So any of the meetings that can happen outside of work hours is beneficial. If you do that um, every other meeting, or if there's some kind of rotation, or if there's a way to change some of those meeting times, it would be helpful, especially at the hospital level. Sunday afternoons at 5 o'clock are golden. I like those hours. You can run it by him and see if it works, but it has gotten so many people from me. And then also you want to be, if they want to be a member of the QI, you want a member of the QI team to be their mentor, their person that they have the contact with, that they know that they can call and ask the crazy questions or the silly questions or the ones that people don't want to ask in the group, guidance, where to get more information. You want that contact to be on your QI team so that they know who it is. It can't be the whole team because that means there's nobody. You want to make sure that you get information about the team members beforehand. How many patients are on this team? Who are the doctors and nurses on the team? That's information that they want to know. And then a little bit of an orientation on QI, the methodologies, the terms, the tools. NicheQ has a really good QI 101 that you could absolutely use to help educate patients. And then there are you want to have examples of things you've done in the past so they can kind of get grounded in how you operate and what you've been working on in the past. You want to talk about what topics are they interested in. It's usually based out of their story. As they get more seasoned, it can be more than that. It could be the general patient experience. But in the beginning, it's usually something out of their story that has, their interest. And then you're going to talk about ways to debrief after the initial meetings. You want to know if things have gone well or if there were things you could improve, and have them, know that you want to hear about it, so that if in fact everything went well the first time, they know they can come to you. If it doesn't, you open that door. Because when we do, talk about people having different experiences, everybody could have had a great meeting except for one person. And you might not know it if you don't open that door for people to be able to explain it to you. And then have brainstorming sessions with them. It's a good way to incorporate ideas that they might have. It's also a good way to feel as a part of the team and to be able to do something that you can actually see move forward. So having those brainstorming ideas together and synthesizing, like we talked about with those stories, is a good way to make sure that people are engaged and feeling good about their work with you. Next slide. And then in preparation for staff and clinicians, you want to have opportunities for them to share their concerns. As we saw earlier, there are people who will, this is new. This is a culture change. This is not how we have done it before. It's not how I learned it. That's not the way we do it. So, absolutely hear those things, and let them voice those concerns and help address them, help them get the information that they need, help them to understand, talk to them, too, about why it's important for you and what you're seeing in these opportunities, and then give them support so that they, have that ongoing support. Bring it up again, talk to them one-on-one, so that there's an opportunity for people to grow into this. And then you want to have strategies to partner with patients and families. So, active listening, you want to make sure that just as we were doing before when we heard that story and you were pulling out things, you want to be listening for opportunities. You want to be focused on, you want to be able to listen for where are the pauses in the person's voice. You want to be listening for where did her voice change? Where did the tone change? What's important to this person? Very active listening, focused on this story in this person. You want to make sure that you are appreciating people who are asking questions. What you reward, you will get. If you reward people who ask questions and interact with you in these meetings, you will get more of it. You want to make sure that you are aware of your bias. You want to make sure that you are working on them so that it means that you're able to be less judgmental. I don't know about less judgmental, and offer that to people as much as you can. And then you want to think about this strategy, which is when you are having a meeting, um, make it a standard that everyone gets to weigh in on some of the important decisions about the direction that we go. And I like doing like round robins. So that is a practice where you have everybody in the room and you tell them, all right, what do you have to add? If someone's already said it and you don't have anything to add, you can, pass to the next person, but you're going to each person and you want to hear from them, what they think about this topic, what they think of what could be added, what questions do they have, and you're going to go to each person. So the expectation is that the parent or the patient also participates in that active discussion, and it's not just the people who get heard all the time. It's a ground leveler to have a practice like that or a strategy like that for patients, so that they know that they're going to have the opportunity to speak and they don't get spoken over. And then after, making those introductions at the initial meeting, when people come in or when they're on Zoom, make sure you're, acknowledging them. Make sure people are doing those introductions so that they can still keep tying the name and the face and what people are doing together, because that might take a while, and it helps orient the staff as well. And then also make sure that you set those group norms and communication. So if in your group everyone just talks when they get ready, and then you have a patient or someone who's raising their hand, those kinds of things can make it seem as if people didn't want to hear from you. And in some cultures, people don't, it's not polite, so they would never break in and have something to say unless they were called upon. So looking at your group norms and setting them up in a way that will make sure that people get their opportunity to speak and that they don't always have to break in. If that's your current culture, I understand, but even saying that to him, like, we just break in over here, and so what would make you comfortable doing that? How can we support you? Kind of conversations. Next slide. Next slide.
There we go. Could we go back one slide? I think we're ahead one slide now. Sorry. There we go. I love technology on a Friday afternoon, I have to say. Yeah, Latasha, I was just thinking about those introductions because people are always asked, well, what, how do you do that? And I'm in one group that does a great job at, doing those icebreakers in the beginning. And one way that this group makes sure that everybody's kind of comfortable is the very first thing they do, and this is after the initial meeting, but the very first thing they do is they pair up in a Zoom room with so they pair me with somebody else that I haven't maybe met before on the team or had a chance to talk to, and we just like engage in a how are you conversation. It's not work related, it's not volunteer job related, it's just hey, how are you feeling, what's your week like, and things like that. There's lots of wonderful ways to get people kind of engaged and appreciated.
I like that.
Okay, yeah. So all right, gonna move on. So years ago, when I was working with the Vermont Oxford Network, which is a collaborative focused solely on newborn intensive care, they had asked IPSCC to help them bring in the family voice to their collaborative work. And this was back in 2000, so 22 years ago. It's a long time ago. And about 3 years after that, they actually hired a family partner to come in, and she and I developed this framework that just outlines the various levels where families can participate and be engaged in quality improvement. It's based on established frameworks in research, but we completely adapted it for QI. So that top row lists the levels of involvement from left to right. So the next, no, keep on this slide for a second, please. Sorry. So let me just take you quickly through those levels. Level 1 is when families are participants in the QI. And by that, I mean they're respondents to surveys or questionnaires. They might be focus group members, as Latasha had spoken about earlier. And it's a time limited, obviously, it's a time limited event for them, but it really can be helpful to start that initial thinking about improvement. It's also can be appealing to the families who either they're not ready to commit to a long-term effort, or they feel that, hey, I don't really trust you yet, so let me do this and let's see how you work with me. That second level, and again, Latasha mentioned this, use your, if you have family advisory boards or councils, they are a great resource for the quality improvement team. So you can engage them to, review forms, projects, documents, what have you. They're just a terrific resource to rely upon. At level 3, families are asked to be occasional reviewers and consultants. A lot of healthcare systems might engage advisors virtually. So there's one that I know, they call them the pajama advisors, because they can be in their pajamas and looking at your documents, your tools, your resources at their own time. But you can, recruit them to engage with you, and depending on their availability, engage them how they want to be engaged. Again, great way to get a lot of improvement ideas. And then level 4 is when families are really involved in as ongoing advisors, partners, and consultants with you. So they are very involved on your committee. Maybe they, for those staff who don't know what you're doing and why are you bringing in families, hey, they could be, they can do some orientation and preparation for the staff. And then level 5, okay, this is really high level. This is where you have family partners like Latasha, for instance, who are going to be engaged as leaders or co-leaders with you. So they're on equal footing and have equal responsibility as the leaders of the QI projects. Next slide, please. So now, engagement in some levels of involvement in QI runs the risk of being superficial. Some people see this, and I've seen it in my own work with improvement collaboratives, that it can be a checkbox, and you really want to not go that way. So there are ways to really enhance and advance the level of involvement, no matter which level. And I'm going to be clear about this. I'm not saying that level 5 is where you want to get to. Level 1, that's where you begin. That's not what this is meant to be. It's a continuum of involvement, and every single level is important to QI. As long as the engagement is authentic. And so I'll just give you a few ideas. Across every single level, Latasha's already made this very clear. Make sure that your participants or your advisors and partners are representative of the diversity of the families who experience care at your setting. In level 1, yes, okay, they can respond to surveys and or be in a focus group, but what about going back with those preliminary results and seeing, hey, does this match what you were saying to us, to get their feedback? Did you capture their responses correctly? Do you want to know how the results are going to be used? Share that information with them. For level 2, you can invite the council to be involved in the planning and implementation of QI projects. There are sometimes you go in and some council members get super excited about the QI work, and hey, if they want to be more involved, invite the council to set up a separate subcommittee that's just dedicated to partner and quality improvement. In level 3, you can increase how often the occasional reviewers and consultants, or family reviewers and consultants, are engaged, or increase the number of advisors that you're working with. So also at this level, as the family partners get more experience, they can be mentors to the newer partners, advisors who come into the QI project. For level 4, make sure that they are prepared. And Latasha spoke about this, so I don't have to belabor it. But too often we do see that families are brought in as a full member, but that's not the way they are really, really engaged. And then that highest level of involvement involves establishing a paid position. So yes, it's very much budget related, but if you want patients or families, women families, to be participating at that level, then create a position for them. Next slide, please. I almost went ahead. Latasha, you want to say something about this?
Absolutely. Okay. So you will have access to this full document. This is just the first page. If it's hard to see, you will get it. But I want to mention when we look at sustainability. So if you are talking about bringing people in, you want to make sure that there is ownership. It's not the whole group. There's somebody who is actively working on recruiting. There's someone who's actively working on making sure that people are oriented. You want to spread this thing out, but you want to make sure that there's ownership for each piece, and there's oversight, and people are doing the check-ins. And then you also want to make sure that everyone understands the perceived value. What new changes could come from this? What are we aiming for? You want to look at leadership, and keep the focus on sustain, so we can keep the focus on sustaining those improvements. So if we're looking at this and we know that we want to do this because it will improve care, there's value in doing that. We have people who are able to help facilitate it. Now we have leadership being able to look at these changes. So, are we able to report to, board of directors at a hospital? Are we able to have them see what improvements have happened as a outcome for engaging patients, building buy-in? Are we able to show that there has been the feedback has come in and we're monitoring and making adjustments as needed? You want to move through these stages, because these things, as of any initiative, this can work with anything, and it definitely works with patient and family engagement. So making sure that your staff have the skills, the knowledge, and the confidence in doing this. So the information we've shared, being able to share that with them and help them to see that other people are doing this. It's not necessarily new, but we are having a focus on bringing in underrepresented communities in the work that we're going to do. And we told you why, and we've shared the stories, and we want to make sure that everyone is comfortable. So go through the process with them, make sure everyone has the skills to do it and that they're comfortable. And then looking at your, internal operations in the infrastructure, and making sure that you are able to remove some of the barriers that exist. You won't know what all the barriers are until you start working on it. But as you do, you'll see the barriers and be able to work with organizational other departments to start to create change. And so knowing who the people are, being able to get access to them, and helping to bridge those gaps. And sometimes it is barriers between, like the story we heard before, NICU and OB, where you have a baby on one side and a mom on the other side. How do we bridge this gap? And then, you can have, those kind of conversations as you move along. So that is going to help as you build out and you build the buy-in. You are able to demonstrate value, and it can spread just like that. And as you do grow, you're going to have to address funding. So some people said, I don't know how to do this. We don't have it in the budget. Initially, you may not have it in your budget because it's new. Um, but at some point you start to realize, I've seen hospitals go out and get community support and ask for donations of gift cards, and they were able to use those gift cards to give to patient partners. That's how they started, because the community supported the initiative. You could also work with volunteer services, and maybe a foundation, and set up, a little bit of a grant. Some hospitals have foundations attached. Set up a little bit of a grant, apply for it. That would mean that you'd have some funding to do this. Maybe it is meals if you're in person, or it's electronic gift cards. I got the most amazing Amazon gift card at Christmas time one year from working with a group, and I needed it. I got it the same day and it was gone. I had a dollhouse I needed to buy. So don't believe that it has to be so much in the beginning. You're just starting out, but when you do build that in and find those unique ways to bring in money to support, patients being a part of the work, it's meaningful. And especially if you want to engage people who are underrepresented. There's not too many people that are going to absolutely continue to show up for free. It's not that many people. And so at some point you have to cross that bridge. And especially when you start looking at, lengthy job descriptions, and we start talking about having people be in leadership, and, those are budget line items. They have to be in the budget. That's not community support. It could be a foundation grant. But as you continue to grow, these are the things you need to be working towards, because it's sustainability that's going to mean that I will tell my friend about, your organization and working with you in quality improvement because I can see that it's important to you. I can see that you're taking the steps to make sure that this continues and that you value me. Next slide. All right, back to Marie.
Great. So for the last part of this session, I'm going to talk about some activities that can get you started. Well, one that's going to get you started and some others that will keep you going. And so one of the very interesting, easy initial activity to do, it's called a walkabout. And it's a great beginning activity to get some ideas for quality improvement. And somebody earlier in the session said, step into the shoes of a patient. Yes, so this allows you to step into the shoes of your patients and your families. So what a walkabout does is examines processes or practices or the environments of the settings through the perspectives and the lens of the patients and families. And that might include the care experience. It might include the first impressions of your unit, clinic, or center. It might also include how the policies or practices and environments support patients and families as partners. You really want to explore the extent to which patients and families are engaged as essential partners of the healthcare team at the bedside or in the clinic. Next slide. So there is a process to it, and in the resource packet, the walkabout is described. So you have that as a resource, but obviously you want to choose the focus. I just mentioned 3 things you could focus on, but choose your focus. Is there a specific practice or process that is problematic that you want to explore? Do you want to keep it kind of general and just on impressions of the settings environment? Keep your group to a manageable size and make sure that it's comprised mainly of patients and families. Include a clinician, staff member or 2 from the setting that you're going to be walking about. There's not a lot of prep for the patient or family advisors who are going to be doing this with you. And that's why it's another reason why it's a great initial step. The only thing that do need to be prepared for prior to the walkabout is explaining the process and what you're focusing on so that they understand what is it that you're seeking to find out about. Let them know that their voice is critical to the process, and make sure you're supporting them. Most walkabouts, you can also let them know that a walkabout, what's the time? Okay, the time is typically 45 minutes to an hour. Sometimes that can vary based on what you're focusing on. And also, you're going to have a meeting post the walkabout where you discuss what you've seen and what it means and what some ideas are for improvement. So just make sure that they understand that. Then gather what you need. So you really do want to be recording using a camera. Your phones are great for this these days, for documenting the insights as the walkabout is being conducted. So you don't have to take photos of staff or clinicians, patients. If you do, so if you're observing a process, obviously you need to ask for permission and have permission forms on hand. So develop a permission to photograph, record, and make sure that it's it's very clear that that's an okay thing. So you need a person dedicated to taking the photos, recording, and gathering the materials. That person needs to be designated. If you're going to examine a specific process like rounds or, your birth plan discussions, then sometimes it's helpful to just have a checklist of what you're going to be looking for. So you can either, you can develop a checklist, what do we want to see or what do we want to be looking for in that interaction? And then that helps you just structure the walkabout. It's super important to make sure that you've informed and gotten permission to conduct the walkabout with the leaders, managers, and staff where you're doing it. It's probably going to be, a place that you are in or you work in, but they still need an explanation. Give them a summary of the project or what you intend to use the information for. If you're going to be observing a care interaction, again, that permission does need to be obtained from the patient or family. And then go ahead and get started in conducting your walkabout. So it really helps to begin where the family begins. Determine the best point of entry. So if you are, if it's, we heard some really good stories from the parents yesterday, and I was just thinking, there was one, the woman might be in one hospital, the baby gets transported to another hospital, or at some point along the journey, the baby gets transported from one hospital, one NICU to another NICU. It just, think about how do parents, how do women and families enter, if that's what you're looking for. And then if you're doing that kind of walkabout where you're looking at the environment, make sure that any area that's visible or physically accessible to patients and families are included in that. You want to capture, quote unquote, evidence. You want to make sure that you are gathering the insights from patients and families, and you're taking notes. You can ask the patient and families, what are you hearing? What are you seeing? What are you experiencing? What are you feeling? Make sure that you're collecting the patient and family information or educational materials that are available in the area that you're doing your walkabout in. In addition to getting the patient family perspective, it sometimes really helps, especially as you're going into an improvement project, to think about the staff perspective. So there might be, as you're going through the walkabout, staff might also come up with, hey, this is really an impediment to my partnering with patients and families, or this policy or this practice, or so those are things you do want to capture, even though the essential voice is the family, the patient and family voice. Next slide, please. So it's not, there we go. So then, as I said, you want to have a meeting after the walkabout, and you want to bring all that quote unquote evidence. You reconvene, and they yield a lot of findings. So you're going to have to sort through and reflect on them thoughtfully with everybody who is part of the walkabout. So make sure that you use an approach to better understand the results, so use that root cause questioning. What did we see? What do we think is really happening? Everybody's going to have a different perspective of what really is going on. So make sure that everybody is participating and responding to that question. How does this relate to our philosophy of care, our mission, our values? Is this something that really aligns with it? Why? Okay, sometimes things really stand out to walkabout participants, and they're odd, or they're like, why does this material or practice or process even exist? Like sometimes things are just done, and staff and clinicians might just like not even think about it, but it might be very something might be very cause some thing to go off for the patient or family. And then think about, how can all of those things that we looked at, we saw, how can we improve? Now, you're going to come up with a lot of ideas. You all came up with a lot of ideas earlier today. So you can, one walkabout is going to yield a lot for you to think about, and you can't do everything. So you have to prioritize, and you can do that. Again, look at the data. Where are your gaps? What do you need to improve? And which one of these ideas is going to lead us there? Link and link these to clear, actionable, measurable goals, and measure the progress using whatever quality improvement methodology you use. You definitely want to keep this in a quality improvement methodology. Next slide. So as a quick example, the Vermont Oxford Network, they do 2 to 3 year collaboratives, and they started one of their collaboratives by asking every single center to conduct a walkabout as a beginning step. And so they explored a lot of different areas. The centers chose their own area, whatever they wanted to explore, whatever they wanted to improve, that's where they focused. So bedside or single rooms were looked at, family areas. Some people, found that their breastfeeding room was unacceptable, reception areas for families. Some people looked at care processes. So the process of rounds came up several times. And they used this to identify topics. And then they initiated projects and developed tools and resources. They also presented this in the second year of this particular collaborative to showcase what they did. And I will say, because they did have some experienced advisors, they did have many family partners co-leading those projects themselves. So it's really interesting to watch that happen. Next slide, please. So I'm going to I'm not going to go into this because I think we've talked about a lot of the value of why involve patients, families, especially those who are impacted by disparities in quality improvement. This is a great resource. And I know I'm giving you a lot of resources today, but maybe you can start a journal club. I would say that, okay, so these are reflections from providers and leaders from a study that was done in the Canadian Foundation for Healthcare Improvement. So the Canadians' version of Institute for Healthcare Improvement, for instance. And they published this terrific article. So it describes 8 years of their work supporting quality improvement and patient and family engagement. So they looked across 51 teams, and they came up with these reflections. And so they're included in this article. So I'm just looking at the time, and I want to make sure that we get to everything we want to get to today. But these, on the next slide, not only did they ask for reflections from the healthcare professionals, but they also asked for patient and family advisors. And I think I do want to spend just a minute on this, because they offered recommendations on what they need to be successful in their role. So they wanted their role to be very clear to them, clarify the role, educate the entire team about the role of the patient and family advisors and the value I bring. They don't want to feel undervalued. Give them the information they need to be successful. Involve them from the beginning. Don't bring them into a project when it's already baked, because that doesn't work. They're not going to be able to help you out there. Including one patient advisor, that's a good start, but it doesn't really work. It's better to have more, and they can act as a support to each other. make the engagement activities accessible to them, and provide other, lots of options for how they can get involved. Promote networking opportunities amongst other family partners, because they can learn from each other. And this a big kind of problem is, once a project has finished, work doesn't continue. So can think about, okay, let's keep them involved. Let's keep going. Let's do another improvement project. I know we've talked about sharing stories, but they want to be clear. Yes, we can do so much more than just tell our stories. So those telling the stories doesn't take you far enough. Make sure those stories are embedded into the improvement. Next slide, please. I'm just wondering if anybody has some ideas for what might they do for a walkabout. Like, do you have any ideas in your head right now? You can chat them in of, this would be really interesting to look at through a walkabout. I will say that in the age of COVID, some places did this virtually. So they had the family partner on the phone and on a phone, and taking them through where they wanted to see and what was important to them. Yeah, the next slide. So I'm going to get started while these slides they're tired, I think. There's a lot of them. So I'm going to just spend the last few minutes here talking about 3 activities, thank you, for you to learn broadly. So involving them on QI teams is great. And obviously Latasha and I firmly believe in it and encourage you greatly to do that. But there's a need to bring in the broader voice too. Now, patient and family partners can bring the broader voice in. They're in their neighborhoods, they're in their communities. They can bring that voice in. Moms talk to moms about their birthing experiences, or parents talk to parents about their NICU experience. So definitely you're going to get a broader voice, but in order to get even the broader voice, you can start doing interviews, discussion groups, or surveys. Next slide, please. So interviews are great. Once you plan an interview, and select a few people to interview, make sure that you're understanding, hey, what's the focus? What do we want to focus on? Who would be good to be interviewed? Excuse me, and then develop the questions that you're going to want to ask them. So you've finished that planning. Well, what's the interview look like? Well, it looks like sitting down with the person, explaining why we're doing this, and what the process is going to be like of the interview, and then the next steps after the interview is over. Definitely use open-ended questions, not yes, no. That's not going to get you a lot of information. And then plan to probe for greater understanding. So if you're not getting enough information, you can just say, hey, explain that a little bit more, or share a little bit more about that. And after the interview, make sure that you're affirming their contribution and showing appreciation to them. Describe to them how that information is going to be used to inform improvement efforts. So make sure they understand this is going to help us do X. Ask them, do you want to hear about what happens as a result of this conversation? And can I follow up with you about that? Latasha mentioned earlier on about families sometimes having, bringing up some emotional responses. And sometimes that happens in interviews. So ask them as you're ending the interview, was there a sensitive topic or an emotion that was brought up, or a memory that you'd like to talk to me some more about, not as part of the interview, or somebody else? And just make sure you follow up on that. Next slide. So here's just some examples of questions you can ask in an interview. Well, not this slide, but so you can just ask some very simple questions, and I probably don't even need the slide to do this. Let me just look at my own slides. Yeah, so, you know, first of all, you want to give them some general questions about what their experience was. You don't want to start off with the big questions. But then if you're working with people who are typically not at the table, are, underserved, underrepresented, then you can ask them, once you get started in the conversation, you can ask them, yeah, do you think we can go to the next slide? What can we do to change or improve to build trust, to be a better partner with you in the future? What do you wish we had done that we didn't do that would have built better trust with you? Tell me more about your trusted communities and support systems outside of the hospital or the center, and tell me how we can build better relationships with them. That's just a sample. Let's skip ahead to 2 more slides ahead, I guess. The next activity, boy, we're stuck here. The next activity, I'm sorry, because I'm going to be talking without, oh, go back, one, there we go. So the next one is discussion groups. So for discussion groups, and I call them discussion groups and not focus groups for a reason, because you can do these informally. Focus groups implies a very formal process. Sometimes it has to go through IRB. Sometimes discussion groups do too. But you will need to have questions and develop a guide for yourself, because you don't want some kind of erratic discussion going on. So make sure that you develop some guide to keep the facilitator and the discussion on track. So your questions should be very clearly worded. They should be open-ended, as I said. They should not have bias. So don't lead them into something that you want to hear. You want to be leading them into something that they want to discuss. And then again, include prompts that might help to drill down some of those responses. You want to have an agenda, and you want to present that agenda to the group. Make time for quick introductions. Give them an overview of the topic you're focusing on and the process for the discussion. Ground rules, and Latasha spoke about ground rules being important in any meeting. You really want to be spending most of your time in the questions and their responses. And then at the end, so somebody should be, I should have mentioned this earlier, there should be a note taker. And that person can then bring up some of the main points and themes that came out. It doesn't have to be overwhelming, because you're not going to be there yet. An overwhelming summary, just a brief summary. And then describe how that information is going to be used in improvement. And then, of course, acknowledge and thank them. One thing, and Latasha brought this up, is provide them stipends or gift cards, something that acknowledges, hey, we really appreciate you taking the time to do this with us. Next slide, please. So we have interviews, which you can get a number of people. Then we have focus groups, which if you have about 6 to 8 people in one focus group, depending on the number of focus groups, you're going to get, a broader group. And then if you really want to go broad, do some surveys. So again, you want to choose your topic. You want to select the population that you want to survey. How are you going to do the survey? We've worked with places that do text surveys with the community. You can do it a paper or card or tablet in the reception areas in your centers, or in, as um, part of a family resource center. You can do phone surveys, for instance. Just make sure that the surveys are not overwhelmingly burdensome to the people. Make it very easy to complete. And then again, you want to take that information, summarize and categorize the responses, and identify your ideas for improvement, and have some way, I didn't put this on the slide, but have some way of feeding that information back to those people who were members of the survey. Okay, I'm going to hand it over to Latasha, because I think you have an example of a group that's done this very well.
Absolutely. So if you have not heard about Battle It Over Birth, this is a part of what you will also get. You'll get a link to this. But they did a wonderful group, about 100 Black mothers in California. They had them complete a questionnaire, and they were able to participate in sharing circles. They got so much information about the care experiences that people had, and got to understand more about, the different opportunities that existed. So what's wonderful here is, with all of those conversations and all of those the questionnaires and surveys that they sent out, they were able to develop some better practices on care. So that's a very good place to look, especially as you start to look for different opportunities to make improvements. And then it's an example of actually how to do the work that Marie just spoke about. Next slide.
Latasha, can I just mention the recent article that came out in Health Affairs that used a similar approach? And so if Health Affairs just did a wonderful issue on challenging racism, and it's open access, and Health Affairs hardly ever makes their articles open access. And there's a great article that did similar work with women in Georgia and North Carolina. So if you haven't seen that, it's the February issue of Health Affairs. I'm sorry I interrupted.
No worries. That was a great document. All right, so let's do key takeaways so we can get a few questions at the end. When you are partnering with individuals impacted by inequities and disparities, you want to make sure that you're grounded in those experiences in your work in quality improvement. And that can lead to better outcomes for all. You also want to, yes, identify the challenges and find ways to overcome them in those experiences, which is something you did a great job at. And then also make sure you're recruiting thoughtfully, and that you prepare for the collaboration. You want to make sure that everyone is ready for the collaboration, because we want to make sure that we're helping and not harming. And you want to start with and with easy to engage improvement activities. So some of the strategies that we've given you here, any one or two of those could absolutely help you to build capacity. And so you want to continue advancing your level of partnership with families and with patients. You want to make sure that you continue to move people along the continuum. We're not just telling stories anymore. We're now acting upon them, and we're moving people to giving them opportunities to participate fully with you guys. Also, you want to commit to listening and to learning from the experiences from broader community. If you have been engaging and your community does not, your participants don't look like the community you serve, then you have ways here that you can change that. If you haven't started, you can absolutely start with that intentionality and build capacity to bring in patients that are underrepresented. And I know that you guys may be familiar. There is the bundle that the Council for Patient Safety and Women's Health Care has, and they talk about ethnic disparities and racial disparities. And one of the cornerstones that they list is bringing in patients and families from underrepresented communities. So I'm glad that you're focusing on this, and that if you haven't started, you will start this way. And if you are needing to make some adjustments, then you know now how to do that. Next slide. All right.
That's the resource packet, so we don't have to belabor that, but we can go on to the next slide because I know.
So if you want to contact either one of us, we wanted to make sure you had a way to do that with via email. So hopefully you are seeing that on the screen. Contact at latasharouse.com, and then mabraham@ipfcc.org.
Yep.
We want to thank you for your time, your attention, your thought, and taking the time to be with us today. We don't take it lightly that you stayed with us this long, and that you have been really engaged. So we appreciate you.
Mhm.
All right, now we have time for feedback, questions. You can put those in the chat. It would be amazing to hear what you have to say. If you got anything that was helpful, if there was any other questions you had.
Right. Or if you want to share an idea,
Mm.
that'd be great. Janet, you're on mute, I think.
It wasn't just me.
Somebody has to. Somebody has
yeah.
to.
Absolutely. Normalizing it for us all. Thank you both. We have just a couple of questions so far. We have about 9 minutes because we are transitioning to concurrent sessions after this. So we're going to try to see how much we can get in. So one, for the Illinois PQC project, did you do focus groups with physicians and other care team members to understand how they define successful care, what matters most to them in care delivery, etc.? I'm wondering if that aligned with patient feedback. Do you think doing focus groups with physician or care teams would help with buy-in for QI?
I have done that, and it was there was some alignment on some things, and then there were some things that didn't. And so, being able to express that this is kind of what patients had to say, and that this was centered that way, helped them to kind of understand there should be a difference. It should not be the same. If you have a group of patients and a group of physicians that agree on everything, we don't need to do this. That's not what you're going to find. So there should be those differences, and expect that. But yes, that is helpful for them to see the differences. So I would say that might be a way to do it. Absolutely.
I completely agree with you. When we do surveys, even we will tease out the healthcare professionals from the patient and families, because that data about where the discrepancies lie is very, very telling, and it's very important.
Awesome. Thank you. The next question, one thing we could gauge in a state as big as Texas, with nearly 250 hospitals that provide perinatal care, how do we identify QI projects that will resonate with the wide range of hospital settings in our state?
I would say one thing that really helps is if you focus on care experiences. Respectful care, that can be any particular organization can work on that. And then if you're talking about, bridging the gap between maternal and NICU, that's also a place. Because there are times when parents feel like they didn't feel respected as their parent of the baby. And then there's, you know, patients who feel like they weren't respected and heard about their own experience. So respectful care can always be one. Communication. You're looking at all of those things that you hear, not being heard, not being listened to, the distrust. How do we build trust? You can ask that question. You can ask them. And why haven't you been able to trust in the past? You can do so many things with the patient experience.
Thank
Yeah.
you.
Yeah. I think that, getting what are the biggest gaps that we can all work on together. And I think any of the quality improvement collaboratives that we've worked with, they'll select, hey, these are the things that are coming up the highest in our data. We need to really improve these areas. And then centers, yes, you're going to tailor some projects for your own environment. But if your collaborative can come together on what is the key critical issues right now that we need to focus on, it would be great. Crowdsource it right here.
Awesome. Our next question. When you have a level 4 or 5 patient engagement, how do you avoid having the patients indoctrinated into hospital culture?
So true.
Good one.
Yes. So I know one thing that, so for instance, Vermont Oxford Network they are at that level 5. However, the way they do it is there's a separate group of family partners that are in constant communication, and they're constantly, they're reflecting. So it's just like they understand, hey, we could go over the edge and go into this, but they keep themselves grounded in the reality. And when they're reaching out to other families in the unit, that's how they stay grounded. Latasha, I don't know, you probably have something to add because you've been part of that.
Absolutely. And that is why I became a doula, because it did give me that access to hearing and being a part of the care experience in a different way. So that adds to what I'm able to bring to groups, because I'm every other week at least in a hospital and seeing examples of what we need to improve on. So there's so many different ways to do that. And it could be what they do. It could be, being supports in support groups for other parents. You can look for people who have those experiences too.
Awesome. I think we have time for one more in 4 minutes with the hard stop at 3:30. Can you give an example of an improved outcome based on insight gleaned from this process?
I can say the one example I love to use is when you look at discharge and you look at, thinking about NICU. We had a patient come in and say, I, I just don't like how my discharge went. I was discharged by a nurse I had never met before. And it meant that I went home and I wasn't confident that I could take care of my baby, because I felt like she didn't know my baby and she didn't know me. So I didn't trust the information I was getting about things I should be doing when I got home. And so that meant in our NICU, we decided at that point we would make those changes. So the people who took care of that baby most of the time were the people who did the discharge. So it was not a brand new person showing up at discharge. Having people go home with confidence helped to impact readmission.
Yes, and I'll just piggyback on that real quickly. Is some centers that did work on the rounds process with their families. So how bedside rounds were being conducted and how families were being engaged in the rounds process. And when they looked at it and measured it, they found that parents at discharge were self-reported that they were so much more prepared to go home. They also felt that they were decision makers, and they also, yes, they felt very ready for discharge. So they also, like, did this take longer? They studied that. No, it doesn't take longer. In fact, it takes less time overall because the families aren't constantly coming back with questions or stuff. So, that's the beauty of quality improvement. You're measuring the success, and you can measure, hey, which idea came directly from the families, and how did that influence this particular project?
Awesome. and spot on in terms of timing. Thank you both for that wonderful presentation and for being so thorough and sharing such great strategies for implementation. We hope you all got a lot out of this session. Just a reminder that you will be switching to the concurrent session, so you will not use the same link. You will use a new link that has been emailed to you by TCHMB. Whether you chose the obstetrics track or the neonatal track, you will use that link provided to you in your TCHMB email to switch links to your concurrent session. Again, many thanks to our speakers, and we're going to go into a break.
Bye, Janet.
Bye. Thank you.
Bye, Latasha. See you soon.
All right, bye.